Hello,
Yes,
everyone.
we can do
Hello.
that. How
Hello,
are you,
Dr.
Dr.
Farooq.
Farooq?
Yeah, yeah, great to see you. Great
Thank
to see
you. We're also happy to see you. By the time we have just 1 minute, if you could share your screen, we will check.
Yeah,
Is that okay?
sure.
Thank you.
Uh, Let me check it.
Mm-hmm.
Yeah, it's like a share, right? So to click the share,
yeah, click the share,
Yes,
that
click
green
the
button,
green button. Yes,
yeah,
and
and
select
then
the screen you want to share it.
okay,
mhm.
yeah, finally found it. Oops.
You can press on the share button and the green button, and
Great, but
after you,
yeah,
yes, and then you select the screen that you want it to be shared. You can open the presentation, PowerPoint presentation, and when you press share, select the PowerPoint presentation.
okay. Uh, this, oops, yeah, no. It's like I should choose from like
Yes, when you press the screen, when you press the share button, it will give you multiple
oh,
screens,
okay,
and then
Uh-huh.
you select the
Yes.
one you want to share. No, we see
Mhm.
it's not a presentation.
yeah,
You
yeah,
can
yeah.
exit sharing
We see your
and share
screen,
again, and
and
when you choose,
Mm-hmm.
you can exit screen sharing now.
Uh,
Uh,
oops.
остановить.
Okay,
Мгм.
okay. First, open the PowerPoint presentation in your laptop. After that, you can press the share button. And when it give you the screen to share, you select the PowerPoint view.
Oh, yeah.
Or you can screen your computer screen itself. That's also an option.
Oh, yeah. I don't know, like how
Uh,
The first one on the left up, entire screen.
so,
You can select entire screen and share entire screen.
entire screen. Yeah.
mhm.
Yes. Then you open your PowerPoint and we will see anything in your screen, we can see it.
Yeah. Uh, oops. No.
Мгм. Фарух Сатарович, там нужно поделиться
Да,
либо
я
целым экраном. Ага.
и
И
навесить.
вот, у вас ваша презентация открыта на компьютере?
Нет, она еще не открыта, но я сейчас ее открою, могу открыть.
Да, вы ее откройте. Да, но не полным экраном, просто чтобы в одном окне
Да,
была. Вот, откройте ее, а
да.
потом поделитесь экраном опять. Share the screen, вот этот.
Окей.
Мгм. То есть вы открыли презентацию, да? И теперь share the screen.
Окей.
Мгм. Теперь сейчас мы увидим ваш... We will see your screen now. 1 second. Мгм. It's still loading.
For some reason, we don't see the screen until now.
Yeah, for some reason мы чуть не можем увидеть your screen. Так. Maybe you can send me your presentation
Maybe
and
you
I
can-
will open it. I will open it and you will just read the presentation. I will click it if you want.
Wait, just okay.
If you can,
Okay.
Получилось?
we
Yeah.
don't see the screen. We
But
don't
we
see
can,
it.
now
Yes,
we can
yes.
see. Yes.
Now we can see it.
Yes, great.
Yeah.
And now can you do the presentation mode?
Presentation mode. Yes.
Yes,
Perfect.
So we can
Perfect.
start 1 second. So should I start? Present?
Yes, Dr. Narisa, please, you can start. I don't see Dr. Anila, so you can take it. Go ahead.
Hello, everyone. We are starting our webinar number 10 of the Comprehensive Neuroanatomy Educational Program. And today we will have our speaker, Dr. Abdul Farukh Karimov, the president of the Uzbekistan Association of Spine Surgeons, board member of WFNS Spine Committee, consultant neurosurgeon of M Clinic, Tashkent, Uzbekistan. And Dr. Farukh will be talking about surgical anatomy of anterior cervical approaches, planes, neurovascular structures, complications, and avoidance. Also, we are waiting for Dr. Anila Darbar. She will be our chairperson, consultant neurosurgeon, King's College Hospital, Dubai, vice chair, Women in Neurosurgery chapter, ACNS, chair, Women in Neurosurgery, AASNS. Dr. Farukh, you can start.
Hello, everyone, colleagues and friends. I really happy to have a talk in this series of lectures. It's a really honor. This is a topic. The name of the topic is surgical anatomy of cervical anterior approaches, planes, neurovascular structures, and complication avoidance. This is disclosure, but it's no relevant today's talk. Actually, we divided to 3 groups. It's like cervical spine, it's like craniocervical junction, it's like C0, C1, and sometimes it's most of the authors in the literature we can see also like Atlanta axial region. It includes C1, C2, and subaxial spine, C2, C7, and cervicothoracic junction, C7, T1. But it's nowadays we have a lot of modification of the anterior approach to the cervical spine, especially it's like for C1, C2, like it's most of them it's created by the ENT surgeons or head and neck oncosurgeons. But today's I just want to share with information and some literatures. A recommendation is transoral approach, like transoral transpharyngeal approach and retropharyngeal approach. And most common we use in our daily practice is approach to subaxial spine. It's like C7, C3 is a transoral transpharyngeal approach. How I said, it's really some several modifications, but it's most common and most conventional of the approach is transoral transpharyngeal approach. But nowadays it's in developing like endoscopic and robotic surgeries, and also it's involving like a cervical spine as well. And sometimes we use it's a depend on the extension of the pathology, especially oncological process. Also, one of the approach is extended transoral approach. There's several types of this. In transoral approach, it's a algorithm. It's a different algorithm, but it's based on the location of the lesion. It's several type of the approach, as you can see. But today I think we should focus on just a standard transoral approach or conventional transoral approach. What kind of the pathology we can use it? It's like, of course, congenital invagination, basilar impression, and proatlas abnormalities, tumors, like cranial setting. If we see the anatomical structures and anatomical consideration of each approach, it's like first we can see is like a soft palate and uvula, and after the incision, we also before the incision we can see the posterior wall of pharynx, and after the dissection of the first layers of the soft tissue, we can just see in our approach like muscular structures. And after that, it's osseous structures, especially like a C1 arch. And after the removing of these structures, we can just face to the odontoid process. Of course, transoral approach nowadays it's not using commonly, but in sometimes, especially is for the higher C1 level, or like in sometimes cranial neurosurgeons they use for the skull base. And as you can see during the surgery, we usually like split the palate by like we usually make incision besides the uvula, and after that we just can open like a ash like a H. Like a incision like a H, and after that, a dissection of the uh, wall of the pharynx. We just like a flap. We can just fix it. Transoral approach, and sometimes we use a little like extended for extended procedures, especially like extended pathology of the C2, which can cause like a basilar invagination. We also use the extend our approach. It's kind of like palatotomy. And as you can see, transoral approach nowadays in this surgery, we use like robotic systems like a Da Vinci, and it's kind of after the using this like technology, it can be reduced of post-operative morbidity. It's modifications in like a transoral approach using it's called like a transoral transmandibular approach. That's usually we make an incision in the like a labiomandibular approach, and I open the in a exposure like a tongue uh, tongue, and it's like a mandibular. And after that, we just make our procedures like removing tumors. Most of the cases with this approach. But if in reality, of course, this is a massive surgery, and it's not just a typical neurosurgical procedures. It's most of this kind of the surgeries. It's doing mutual with the head and neck oncologist. What kind of the complication we can see on this approach? It's of course it's like a CSF leak and pharyngeal wound and infections and like developed pharyngeal or palatine incompetence. It's usually mostly it's related to like approach complications and also like dysphagia. But for like a prevention of these complications, in most of the cases, it's just a meticulous and closure of the each layers in each tissues properly, and can be avoid in some complications related to our approach. For this approach, of course, we should consider and several steps and several key points like optimal and dental hygiene, loose dentition of the should be protected with the dental guards or remove it prophylactically, like pathological teeth. And if the tracheotomy should be considered in patients with the vagal or hypoglossal glossopharyngeal nerve dysfunction. Patients with impaired swallowing dysfunction may be malnourished, and preoperative nutritional support should be considered to improve post-operative wound healing. And also another key point that transoral transpharyngeal techniques can be particularly challenging in some children or adults. In that case, we should choose more aggressive like transmaxillary or transmandibular approaches should be considered. The next big approach is anterior retropharyngeal approach. This is almost similar indications. It's most of the neoplasms, infections in post-traumatic instability, in inflammatory conditions, and of course, instead of the transoral approach, there is no any absolute contraindications, but in reality, if we know that like anatomically the patient's level, like upper cervical spine level, is not proper for our like a traditional like Smith-Robinson approach, we can also use this retropharyngeal axis. This is a typical anatomical landmarks that we can just know and to see. It's like a hyoid bone, like a clavicle, and medial board of the sternocleidomastoidus. This is also the anatomical considerations of the several like bone and cartilage structures. The first step, of course, it depends on the left or right side we choose. If it's a classical typical anterior approach is called like Sibley type. It's usually doing the submandibular incision, and after the dissection of the platysma and dissection of the platysma, we just going the inside, and we can just face to the superficial layer of the fascia that's usually placed under the platysma. And after the dissection of the platysma, The next step, we just should identify three anatomical structures. It's the gastric muscles, hypoglossal nerve, and superior laryngeal nerve. This is like an anatomical landmark under the platysma muscle. The next step, of course, we should identify as like a middle layer of the deep cervical fascia that which should be dissected just medial and along the carotid sheaths. Okay. The next step, if we to see like or identify the like a transverse process of C1, we can just open our exposure. And as you can see, it's finally we can see the C1 arch and the body of C2 and also the disc of C2, C3. This is key points of the retropharyngeal approach. That's one of the important things we should avoid, avoid the superficial cutaneous nerve on the sternocleidomastoid muscles and identify the medial edge of the sternocleidomastoid mastoidus and know where the carotid pulse is at all times and isolate of hypoglossal nerve before the ligating and dissect carefully to retract the esophagus from the spine. And insist the prevertebral fascia in the midline, not the innerlaterally. It's a very important point that we should work in a prevertebral space just on a midline. This is potential complications and risks. There's also like a dysphagia, pharyngeal anesthesia, and predispose to the aspiration pneumonia, and esophageal perforation, CSF leaks, and Claude-Bernard-Horner syndrome. Of course, for each complications, we should use in some techniques. For the dysphagia, we usually try to using the proper length of our retractors, and for the pharyngeal anesthesia, it's we should of course, as I said, to identify and preserve superior laryngeal nerve. For esophageal perforation, we should inject into the esophagus to identify the site of perforation in the case of the perforate of the esophagus, and which must then be closed in two layers. CSF leaks, it's almost the same as we use in our daily practice. It's like a facial. We use like for repair. We usually use substitute or facial autograft over the site of the leak and place of biologic fibrin glue. And of course, just to avoid the massive traction of the neurovascular bundle, because it's can cause of the Claude-Bernard-Horner syndrome with the ptosis and meiosis and a hypesthesia on the face. The next and most common use in our daily practice in anterior approach to the subaxial spine, almost the similar spinal pathologies that can use it, like degenerative trauma, tumor, inflammatory, deformity, especially kyphosis, and iatrogenic, deformity or pathology, and of course, like congenital. It's actually for subaxial spine, we have also several approach, especially like anterior and anterior lateral. Most commonly using our approach, like for subaxial spine, it calls sometimes anterior or anterior lateral. It doesn't matter. It's a classic, like a traditional Smith-Robinson approach. But before that, of course it will be helpful if we know what kind of the triangles, which kind of the triangles through we work like. But for like for spine surgeons and for spine surgery, of course, it's more important like carotid triangles, like muscle triangles, and submental triangles that we also a submandibular triangle that we use like a retrofrangal approach. And in cervical spine, there are 3 layers of a fascia, like an investing layer, pretrahel layer, and prevertebral layer. The deep cervical fascia, there is several deep cervical fascia, and of course for us, as I said, 3 fascia, especially like a middle layer and like prevertebral and superficial layer, it's very important. Of course, as I said, for the anterior approach to the subaxial spine, we mostly we use like 2 approaches, like Smith-Robinson. That's most commonly we used, and Verbis approach that's usually used for microforaminectomy on cervical spine. That's just a difference in a regarding to the musculus longus colli. It's a if you use like a more laterally, it's like it's a Verbis approach, and but if you using more medially approach to the spine, it's called the Smith-Robinson. After our incision, as you can see, the muscle, like a platysma muscle, sorry, that's and the most nervous supplies from the cervical branch of the, as you can see, the fascial nerve, and begins in the region of the mandible. And after in mostly it's depend on the how many levels on how many levels you work. Like if until the 3 levels, we usually do like a transverse incision. It's depend on the level, but if you want to work more on several levels, 3 and more, we usually like a longitudinal incision. It's also important, like how many, what kind of the ventral musculature we can face during the surgery. It's a superficial layer that's, I mentioned it, like platysma and sternocleidomastoideus mastoideus, and deeper layer like scalenus, longus group, and infrahyoid muscles. What kind of the anatomical landmarks after the opening the exposure platysma we can see it's like hard palate, lower bordal, and hyoid bone, thyroid cartilage, cricoid cartilage, and carotid tubercles. This it's very important in our approach, like carotid sheath. It's in several its contents in several vessels. It's kind of common carotid artery, like internal jugular artery, and a nerve, and like nervus vagus, and some associations like sympathetic trunks. If you if after the opening the platysma and we go to the deeper, we can it's next slide, sorry. And the next our step, it's we can exposures like sometimes sharply or on like a blunt dissection, and like medial border of the carotid sheath, and like a laterally sternocleidomastoid muscles. We go forward, and but in this step we don't recommend. Usually, it's a no recommend to put any retractor in this step. It's just using like I mean, like don't use self-retaining retractors, but we can use bluntly or sharply dissection with just a common retractor. After the open, but initially, let me talk about the carotid artery and its segments. As you know, like 4 segments, we usually can see. It's like preforaminal, foraminal, and atlantoaxial and intradural segments. In sometimes we can see some variations of the vertebral artery, but in most of the cases, like almost 90% of the cases, we can see like a second type when the under the transverse process C6 vertebral artery runs up. And vagus nerve also, it's very important. Like two recurrent laryngeal nerves is it means it's a branches of vagus nerve. If you look at the anatomical landmarks, carotid arteries bifurcations, it's like in a common carotid artery bifurcations, it's like a close or around the C4 vertebra, and internal carotid artery really it's a high variable, and in 64% it's placed in front of the lateral mass of the C1. In the next step, after our exposure, we can see musculus longus colli and also like a scalenus muscle, but we just like retract them, especially like after the retraction of the carotid artery and also esophagus, we can see prevertebral fascia. And usually before the exposure of the prevertebral fascia, usually we do the X-ray marking, and it's after the placing the needle in appropriate vertebral body, we identify the just level correctly. If you can see, we just also we can use a blunt or sharply technique with the Bowie, open the prevertebral fascia and dissect the ALL. And it's very important if we should put our like a Caspar or other retractor systems under our retracted muscles muscles, because if the put the retractors more up upper than muscles like a longus colli, it can be risk of the damage of the laryngeal nerve. This is sometimes the different surgeons use besides the transverse retractors, also like a longitudinal retractor. It's also helpful, but in sometimes it can be reduce your space to work. And this is a neuro foramen that we also knows. It's a lens and vertical diameters, also very important. It's in summary of the main surgical steps. It's a marking of incision, a skin incision, incision of platysma muscles, transverse or longitudinally, depending on your approach. It depends on how many level you're going to do the surgeries. And we should know a localization of carotid artery and mobilize that laterally. And mobilize the trachea and esophagus with adjacent muscles in the fascial sheets medially by blunt dissections. Placement of the lateral retractors blades underneath the longus colli muscles. That's I mentioned it. Placement of screws in vertebral bodies for longitudinal traction, and of course the control of cuff pressure. This is what kind of the complications of our anterior cervical approach we can see, but luckily there is not too many complications after the anterior subaxial approach, especially approach related. But anyway, in your practice, you can face it in some like dysphagia or esophageal injury, vascular injury, so rarely actually, happily, and nerve root injury, the infections. And these guys, we had a surgery, we did the surgeries more than 10 years ago. And if you can see, it's like some infections under the skin, and probably it's after the sutures, it's not the proper suture probably, and dural tear and spinal cord injury and post-op hematoma. And inadequate decompression, it's not typical, maybe it's a approach-related complication, but in sometimes we can see it in our daily practice. And most of the symptoms, it's like vocal difficulties. It's a hoarseness. In some others, they mention about like more around up to the 20% but unfortunately, and sometimes they mention about 4% of persistence hoarseness and difficulties in swallowing, and sometimes it happens. It's especially if you do the surgeries on several levels, especially as the risk of the swallowing difficulties is increasing, depending on how many levels you do. It's more than 2 levels. It's more risky, of course. And 3 levels, it's sometimes it may happen. And esophageal injury, of course, it's dissections, bursts. Sometimes when we use like a drilling or using bore on especially removing the anterior osteophytes, and and sometimes we can just but it's so rarely fortunately it's rarely complications like sympathetic ganglion injury. It can be we can see the Horner syndrome in that case. In vertebral artery injury, if you do the like a typical or a more traditional approach, and you go on a midline on a subaxial spine, we don't see such kind of the complications. As you can see, this is a case that was done my junior staff. It was a recent case actually, but as you can see, for patients, luckily it's not a screws, it's not a penetrated like vertebral artery is a canal. But anyway, it's some risky, especially for the patients with the osteoporotic bone. It can be some risk, but uh, of course, if they penetrated to the vertebral artery canal, like a more unless 1 or 2 millimeters, it's not not dramatically. But as one of the main important point, we should remove the anterior osteophyte, and for the proper placing of the plate. But in sometimes anatomical in some anatomical features, we can see not like a surface of the vertebral body like a flat, and sometimes it can be more like a close to the like a triangle, like in this case. In that case, of course, is there is no any so many like several levels ACDF or like corpectomies. It can be maybe like you can use like a standalone cage. But of course, if you use like a more rigid fixation with plate, it can be try to placing the plates properly, like on a midline and strongly midline. This is also the case with it's mine, unfortunately, but the patients has a comorbidity such dystonia and severe dystonia. In a couple of months after the surgery, we observed like pulling out the plate. Of course, we removed and just observing, and uh, after the normalization of her like a dystonia, we're gonna do the posterior surgery. How we can avoiding approach-related morbidity? It's like, of course, first of all, should be proper pre-op assessment, determine the location of pathology, alignment of cervical spine, like vascular architectures, and to see how the osteoporotic bone. and it must consider the patients before the surgery has swallowing problems or no. And of course, aged patients has tended to more complication, especially like swallowing problems. Also, during the dissections, how we can avoid the complications? It's as I can mention, like a midline plating, dissect muscles laterally and put the retractors under the muscles. Don't exposure and don't go the laterally to the transverse process, and deflate the endotracheal cuff if the you have a surgeries like underneath like a C5 or especially C6, and in it's depend on the your uh, uh, depend on your up to the surgeons using the up-down retractors, and of course like evaluate lateral X-ray after the placing your pins for your distractors, and always use magnifications. And of course, microscope, it's more it's better options than loops. And what kind of the complication we can see it, and it's esophageal injuries like anterior infections, hemorrhage. Also, I mentioned about that. But for esophageal injury, we can prevent by placement of the retractor blades under long scully, and anterior infections. It's most common. It can be happen in esophageal injury, and try to avoid it of esophageal injury. And for hemorrhage, we can just a ligature of thyroid arteries and placement of retractor blades under the long skull. It's again, the damage of injury of the recurrent laryngeal nerve palsy with just a control of cuff pressures and placement of retractor blades under the long scully muscles. And Horner syndrome's just a limited retraction of long skull as well. And brachial plexus injury, and just it's a positioning of the patients, and just try to don't distract of the arm from the body. This is just a take-home message. Of course, anterior approach is a really powerful tool for cervical spine pathologies, and just for minimizing morbidity, just analyze all pre-op symptoms and imaging, and just try to focus on the positioning and operative techniques. Okay, thank you. Thank you for your attention, and a happy Ramadan, and upcoming the Eid al-Adha.
Dr. Abdul Farouk, thank you so much for the great presentation. It was indeed important information, and thank you very much for sharing your own experience in terms of complication, first of all, because we see a lot of good cases, but not everyone is ready to share the complications. And quite difficult topic, as well as others. If anyone has questions or comments, please put to the chat or raise a hand. I have one question regarding the Da Vinci robotic system. Is that the system which you use at your hospital?
No.
In M Clinic?
No, it's not our practice
Mhm.
even though it's developed like last decades I think so, but I just, of course, I saw in some literature, but I never seen in a reality how it can used in a transoral approach. But
Yeah,
probably it's also it's like developed by oncologists because they use a lot like a robotic system. But anyway, but of course for the decreasing and reducing of the complications like transoral approach or sometimes um to especially transoral approach, it's maybe useful like endoscopic technique, especially because just a traditional conventional transoral approach without palatotomy, it's not a efficiency in sometimes because it's so small window to remove the odontoidectomy or maybe higher because it's still using transoral approach, especially for severe like basilar invagination, especially like a rigid and fused level. But in most of the cases in our daily practice, I actually saw this transoral surgeries in my residency program. Of course, it was used like more like a old-fashioned
frequently
technique
in old-fashioned way.
and old-fashioned instruments. Of course, that in this in those cases was so very high morbidity, but of course, nowadays, like instead of the anterior like transoral approach, most of the surgeons use like a posterior like a C1 C2 fusions that can be helpful, especially with the patients with the unstable C1 C2 or C0 C1 segments. And that's my point.
Mm. Yes, thank you so much. You mean now people are mostly moving away from that old-fashioned approach because it has, it's not only about complication, but even though if it goes without complication, post-operative rehabilitation will take time.
Yeah,
Like,
of
yes,
course. For such kind of the surgery, it requires so good equipment and so I mean like a multidisciplinary hospital or something like that.
teamwork.
It's like because
Mhm,
team work approach, especially some ENT or like ICU doctors or something
mhm.
like that.
Thank you. Uh, Dr. Ahmed, you have any comments?
Thank you, Dr. Farouk, for this very nice presentation. You show us a lot of information. And regarding transoral approach, do you use it personally or just mention it?
No, in my own practice, I never use it. How I said, I just observe it in my residency program. But now it's most of the close, especially basilar invagination, we can just can achieve the reduction with the posterior approach. That's my point.
Yes, that's good. Thank you for this presentation and thank you, Dr. Narjiza. Dr. Anila, unfortunately, she apparently he
Will
couldn't
join.
join. Yes.
Okay.
So if there is no any questions or any comments, maybe you can conclude the session, Dr. Narjiza.
Yes, so it was our webinar number 10. One more time, thank you so much, Dr. Abdul Farouk, Dr. Ahmed, uh, Mr. Imad, Professor Salman Sharif, for weekly hardworking staff and presentations. And I hope we will see each other next week.
Yes, inshallah. Next week
Inshallah.
it will be Eid al-Fitr, but we will be there inshallah also. So
Inshallah.
see you all inshallah next week, and happy Eid to all. Thank you very
Happy
much.
Eid. Thank you so much.
Thank you so much, and
See you.
rest with the upcoming Eid. Thank you.
Eid Mubarak.
Thanks.
Mhm.